Once again, I want to welcome you today to the HIMSS Washington Virtual Summit. This is session 5. HIMSS Washington is an all-volunteer board that supports the Washington market. We're made up of providers and vendors and those associated also in education in our marketplace. And we put on events, opportunities for our members to connect. We have education and allow our members opportunities to lead like this. As the president-elect for HIMSS Washington, I want to welcome you to this session. Before we start, I'd also like to recognize our veterans. For those that are off today and taking this on, we do appreciate your service. And for those that are veteran families, we appreciate the sacrifices you make as families of veterans. So at this point, I'd like to introduce our speaker today. It's Tom Leary, who's the Senior Vice President for Government Relations for HIMSS National. I mentioned that we are a volunteer organization, HIMSS Washington. The only way that's possible is we have a very robust national organization that supports us and international operations. So we're very happy and appreciate their service. And Tom Leary comes from the head office. He's the Vice President of Government Relations for Healthcare Information and Management Systems. He leads the organization's public policy initiatives, policy analysis, and outreach. With no further ado, I'd like to welcome Tom and thank you again for being here today.
Thanks, Dwayne, and thanks everybody. I appreciate the opportunity, and I too want to echo the thanks to all of our veterans and all active duty members and their families. It's just very important role that you all play and have played in our country's success. So looking forward to a good conversation here, and again, thank you to the veterans for their service. Again, my name is Tom Leary. I'm Senior Vice President of Government Relations for HIMSS, just elevated to the executive leadership team about 3 or 4 weeks ago. So they're hoping that I won't turn over the apple cart too much, but what an exciting time to be part of public policy. So looking forward to all of those levels of conversations. But today, really, we want to talk to you about what's happening and what we anticipate for the remainder of 2020 and into 2021 for HIMSS as an organization and for the health IT as an issue. And there we go. All right, so just for those of you who have not seen recently, just what as a mission-driven nonprofit, we offer unique depth and breadth of expertise in health innovation, public policy, workforce development, research, and analytics. And just overall, as an organization, we've grown to about 350 employees throughout the world with operations in all those different locations. Just thankfully, we have members, 83,000 members, across the entire, that represent the entire spectrum of stakeholders within health IT. Our vision has changed within the last year, and I tell you, it makes it a lot easier to get up in the morning and do the kind of work that we do, because, I mean, how can you go wrong with a vision like this one of realizing the full health potential of every human everywhere? And as HIMSS expands our reach into all 7 continents, with hopefully with some stronger engagement with Africa in 2021, we will be focusing on that vision of reaching that realizing that full health potential of every human everywhere. And it's I think as an organization, we've really nailed it with respect to what the vision is and what health IT can do to support it. Our 5 key pillars within the organization, and how are we leading with member value? The 83,000 members have asked for whether it's information or opportunities to grow, and we really want to focus on enhancing the member value throughout the remainder of this year and into 2021 and really beyond. And our thought leadership, as we'll talk through today, advancing the vision of the organization and making sure that it's not just the haves that benefit from the access to information and technology, but it's everyone. Maturity model reach, there's, it's somewhere in the neighborhood of 100 million people across the world are impacted by organizations or receive care at organizations who have been reviewed and are by our maturity models, and our maturity models are helping those organizations and therefore the individuals that are seeking care at those facilities to really mature and improve the patient experience, the provider experience, and the overall healthcare experience. Innovation, goes without saying that is key for success in the future is through innovation. Sometimes there's tried and true methods, but tried and true methods in the 21st century with innovation and with technology supports can really deliver on that vision for the organization and for the healthcare community. And then finally, expanding internationally. We, of the 83,000 members, about 65,000 are U.S. based, another 4,000 or 5,000 are Canadian based, and then throughout the rest of the world, you've got just shy of 10 or 12,000 individuals, and really being able to, because our issue is so borderless, because interoperability, because cybersecurity, because value are all borderless topics, we anticipate a greater conversation. And how does that fit into what our GR team is doing? And we focus on three key areas as part of our strategy of, one, ensuring that HIMSS is the trusted advisor on all policy matters. Here in the United States, we've built that over the course of 15 years from one individual as a contractor working on government relations work to now a full team, as well as wonderful volunteers across the country and across the world, really starting to help policymakers at the local, state, provincial, regional, federal, national levels begin to understand that when they talk to HIMSS and they talk to our members, they're getting a practical and reasoned approach to policy development or policy change. Secondly is really that influencing government decision making, whether it's through leveraging the members that I've just described a few moments ago, or it's organizational resources, whether it's the maturity models or our national treasure of folks like Jonathan French who embrace who are subject matter experts on issues like quality and privacy and security. It's staff and its members and its resources, and finally coalition building, and I'll talk a little bit more about coalition building as we take a look at what's to happen in the next few weeks. But we're very proud of the fact that whether it's HIMSS leading or HIMSS holding hands with others as we make change, it's that type of atmosphere that the organization has and GR really embraces. Finally, and this is something that we've gotten a little bit away from until the last 12 months, is the thought leadership, whether it's research or advocacy or development of credible policy positions. That's the key. What we found was a missing element for us. And so if you look at the new white paper on call to action on COVID-19, that's really intended to help governments address this second wave or the continuation of the first wave, depending on what your vernacular is on the issue. But really, it's a call to action on what governments can do to help providers in their communities, providers in their states, their provinces, their countries address the COVID, the challenges of COVID and the challenges of the pandemic. or it's the it's the very pointed telemedicine white paper that we've developed for here in the United States and what changes need to make. It's that type of work that we hope that will be of benefit to you and to policymakers across the world. Our role of our GR team, I don't want to be too much of a commercial, so this really is just another way of saying what I've said a few moments ago for different visual learners. But our responsibility to you as members and to the community is to create content and resources that inform and to create content and resources that drive action. So whether it's policy change that a policymaker will, the action that we want them to make, for example, the telehealth waivers that were put in place for the pandemic through Medicare and Medicaid, to make those permanent. That's the type of action that a policymaker might take, or for us to ask you as HIMSS members to reach out and to educate your governor or your members of Congress. Adam Smith, the chairman of the House Armed Services Committee, has seen the importance of health IT to the defense community, to the active duty family members and retirees, but getting him to take action by you taking action to send a note or sending a letter. It's those types of things that we really push on. And our strategic foundation as a team and as an organization it fits into the vision of the organization by supporting healthcare transformation, expanding access to high quality healthcare, increasing economic opportunity both for the individual and the organization, and then finally making communities healthier. All four of these items have really come up throughout the pandemic and throughout 2020, but none more than the third item of economic opportunity. And as countries are struggling with the idea of how do we get information as quickly as possible to providers, what HIMSS has been suggesting, and through our global consortium for e-health interoperability that the United States and the Netherlands and other countries are starting to embrace, is the idea of common interpretation of standards. So our global consortium is a partnership between the U.S., between HIMSS, HL7, and IHE International, is intended to first address the issues around the fire standard and apps that are built off the fire standard, so that information flows quickly, whether it's in the pandemic or it's insurance data for through the Da Vinci project. It's really that opportunity for the individual, if they build an app, that they have the opportunity to sell it somewhere in the marketplace, whether it's here in the United States or elsewhere, or a healthcare organization can feel rest assured that if the app is built off of a common standard that is recognized across the world, and the common interpretation of that standard is recognized across the world by governments, that those healthcare organizations can purchase products or solutions from anywhere in the world. So that's really the policy angle for us on the economic opportunity and making communities healthier. It's really it's been so highlighted by the pandemic of whether it's the telehealth issues that we've been the waivers that have been put in place that we're advocating that they be made permanent, or it's the public health infrastructure improvements that HIMSS and a coalition of the willing have been talking about for 2 years now. And finally, there's real funding for public health infrastructure improvement, and what is commonly known as the Data Modernization Initiative that's been started by CDC in partnership with states, local communities, and local and state and regional and county public health departments. It's those types of things that we're really pushing for. Our priorities that are borderless are in these three key areas of interoperability, connected health, and cybersecurity. And I'll be talking a little bit more in a few moments about the policy side of cybersecurity, because at every turn, it seems like healthcare is under a bit of a siege, from cyber attackers, whether it's healthcare systems here in the U.S. or worldwide. With leadership in an upside down world, let's all nobody anticipated in January of 2020 that this year was going to go the way it has, save for I'll just say no one really anticipated it. But what do we do about it is really what from a policy perspective or elsewhere that I really think that we want to be highlighting today. And the way that I usually think about things is, start by doing what's necessary, then what is possible, and suddenly you are doing the impossible. So if you think about the policy change here in the United States, from the idea of a meaningful use program to actually now a healthcare system that is 93 to 97% has electronic health records in the hospital setting, and somewhere north of 90% for providers' offices. It was that doing what was necessary from a policy perspective is what's given us the foundation from which organizations were able to react to the pandemic. It's that next step of where else do we need to start to do something different that has really been is key for the remainder of this year and into 2021. So thinking through, just as a backup, what did HIMSS look like in March of 2020? All of you lived through the idea of a global conference happening in Orlando, and 82 countries going to be represented, 45,000 participants, leaders from every corner of the world going to be participating, whether it was North America, Europe, Middle East, Africa, or Asia Pacific Rim. They were all coming to Orlando. And the first sitting president of the United States had been announced that he was going to be speaking, and on Monday, it was announced on Monday, March the 2nd, that he would be speaking. But then the COVID stories started skyrocketing by Wednesday, March the 4th, and literally 72 hours later, we were from the announcement of the president of the United States speaking. 72 hours later, we were announcing that the conference, for the first time in its 57-year history, was not going to occur as a face-to-face. But healthcare has really responded to COVID-19. We talked about the public health emergency declaration and HIPAA waivers as early as mid-January by the Secretary of Health and Human Services, helped communities, places like San Diego. There were big headlines that they were waiting to use their emergency funds until there was a public health emergency announced. And so HHS stepped up and declared that public health emergency. There was a rapid expansion over the course of March and April to the point of, in telehealth, 130% increase in telehealth visits for Medicare patients just between March 1st and April 30th. Healthcare organizations began to think about different ways of triaging capabilities. They were launched, and whether it's drive-by testing or some of the tents that you heard about in parking lots at healthcare facilities. The little-known fourth mission of the Department of Veterans Affairs was activated, and there's a law from 1980, I believe it's 1983, that requires the Department of Health and Human Services as its fourth mission to assist the country in healthcare crises, or whether it's a pandemic or a flood or a hurricane, and it took time for the VA to stand that up. But it was a clear response both on the IT side, hiring new individuals who might have been laid off from their other organizations or were on the beach or on the bench, an up to 2-year IT opportunity with the VA as the VA reached into these communities, or the clinician, as well as clinicians, not just IT professional, but clinicians as well. Public health was suddenly very important. As we saw, the president's budget request for 2020, for the 2021 budget was $30 million for data modernization, which was just a drop in the bucket compared to the $550 million that have been appropriated during the pandemic, as well as just prior to the pandemic, to help make sure that public health is more robust and can answer the call that is currently underway. And finally, not finally, but contact tracing and e-case reporting. The jury's still out on how we're doing on that. My sister's a public health nurse, and she describes some of the frustration of trying to track the contact tracing and to truly understand issues, or for what who an individual has come in contact with. But maybe in these next few weeks we'll see an embracing of the importance of contact tracing, but the jury is still out there. E-case reporting, there's so many stories throughout the year that that very robust infrastructure of 90+% of healthcare systems having an electronic health record, but when they had to then report to the public health department, it's whether it's 18th century technology of a stubby pencil and a piece of paper, or it's the 20th century technology of having to fax into the public health department. It's that there was, between the rush of individuals needing testing and the challenges of going from a 21st century solution with an electronic health record to a non 20th or 21st century solution, whether it's faxing or paper-based for the public health departments, the e-case reporting or the case reporting problem increased over the course of the summer and into the fall, where 75 to 80% of the data that's necessary for making proper public health decisions, 75 to 80% of that data is missing. So how do we move to e-case reporting so that the information that's collected in the electronic health record can then be transferred over to solutions that then can be reported to the public health department? We also, from a HIMSS perspective, we obviously moved to a digital platform and implemented business continuity measures and learned a lot about non-health IT policy landscape. And we can talk about towards the end, just what it means to be an organization that relies, 50% of your annual revenue is based on a conference that did not happen, and therefore an insurance claim, et cetera. We can talk about that more, but really the health IT community, has gotten active. And what I want to talk about for the next few minutes is the idea of what we need to do for what we need Congress to do between now and the end of the lame duck session, which we anticipate being right around the second week of December, is the idea of these public health emergency provisions, whether it's the Office of Civil Rights waivers to allow for FaceTime and other solutions to be used that they would not be HIPAA violations, or it's the ability for non-traditional telehealth providers to be able to utilize telehealth to ensure that patients have access to care while they're protecting themselves from overexposure in a face-to-face healthcare setting, or it's expansion of the types of providers that can utilize telehealth and digital health resources. Those are the types of things that we're trying to get made permanent before the end of the calendar year and before Congress goes out the second week of December. The idea here is that, if you recall from a few moments ago, I talked about how the public health emergency was declared in middle of January, and as part of the CARES Act in the third week of March, Congress gave the Secretary of Health and Human Services the ability to waive certain restrictions on telehealth use as long as the public health emergency was in place. The Secretary and his staff should be given credit for not declaring victory on the public health emergency too soon, but as it was getting ready to run out, the law requires that there's a sunset on the date, or with the ability to extend. As the public health emergency was beginning to get close to running out, the Secretary reauthorized or renewed the public health emergency both in July and again recently in October. So that's good news, but there's only so far that the agency can go without legislative relief. And in order to, without keeping the public health emergency in place for in memoriam, for time in memoriam, and to allow for more provider types and more facility types to be able to use telehealth, we need that legislative change from Congress. So making the public health emergency provisions, particularly around telehealth, permanent is absolutely a must for the healthcare IT community, and for one of the main issues that HIMSS is pushing for the end of the year. Secondly is working together on Patient ID Now and Patient ID Now Coalition. Since the Appropriations Act of 1999, so literally 22 years at this point, there has been a provision in the law, in the Labor, Health and Human Services and Education Appropriations, that precludes the Secretary of Health and Human Services and HHS from promulgating a patient identifier or patient identification strategy without first consulting Congress. It seems pretty straightforward. The challenge has been is that for 3 administrations, the end of the Clinton administration, both terms of the Bush administration, both terms of the Obama administration, there was an understanding that you can't use any funds towards a national patient identifier or national patient identification strategy meant stay completely away. So what we and HIMA and CHIME and a bunch of other organizations who have had a loose coalition around this issue formalized our coalition in May of this year and really began to push on the idea of getting HHS to be an equal partner, and so that we can have a national patient identification strategy that ensures that the Department of Health and Human Services is involved. And I'll say that for the last 2 years, and give great kudos to CHIME and to HIMA, our partners, as well as Intermountain Healthcare has been very active, and a few other great organizations have been founders of this Patient ID Now Coalition. They've made great progress by getting legislation passed in the House of Representatives. The challenge and what we need to address here in November and by early December is the Senate continues to say that you're creating a slippery slope towards a unique patient identifier, and therefore that will be controlled by the government. The data will land in the government database, and the privacy advocates are incredibly concerned. The problem is that policy and that perspective does not take into account all of the identification challenges and all of the needs of, as simple as, if you don't have a correct way of identifying an individual, there's lots of money spent on algorithms and lots of different workarounds that organizations have come up with. But if we're looking at the pandemic, for example, and and an eventual vaccination, just one second. We're looking at a situation where if you don't properly identify the individual and they receive the first dose, if it's a multi-dose vaccination, for example, how are you going to make sure that in this very important international pandemic that that a person has gotten both doses or all 3 doses, whatever it ends up being, so that you've got to so having a patient identification strategy that addresses this issue and is allowed to move forward, so that is really a big issue for us before the end of the year. Getting the Senate to agree to remove the ban to allow HHS to be a full and active partner in this national discussion is absolutely critical. The third piece I will say, and I mentioned it a little bit before, is public health infrastructure improvements. We have learned over the course of our coalition has learned over the course of 22 months that there are 159 different IT systems just within the CDC, and every time there's a new problem comes up, there's a bit of money that's given to CDC to address that particular problem, and the funding must go towards that problem. Well, if you take a step back and you think about 2019, for example, in January of 2019, when our coalition was started, we had the measles outbreak. So if Congress had done what it normally does and thrown some money at CDC to come up with IT solutions to address the measles outbreaks, in Washington State, you have a great understanding of that outbreak, then we would have had 160 different systems. But by July of 2019, we had a completely different public health emergency in the e-cigarette lung disease that was rising, particularly amongst teenagers and the 20-somethings. So if you're Congress, normally you'd throw more money at that problem, but just 6 months apart, what are you going to choose? Item A, the measles, or item B, the e-cigarettes lung problem? Instead, what we're suggesting and what is being pushed forward with Congress is the idea of taking a step back and making sure that there is a foundation for response to public health challenges, whether it's the pandemic that we're in or the next problem that comes along. It's making sure that the public health infrastructure, both IT solutions and workforce, are addressed. So there's been $550 million appropriated, and in the last 12 months, most of which has been part of the CARES Act, the $500 million. But what we're expecting is a discussion within Congress over the next several weeks. The House has appropriated $100 million, and the Senate for 2021, and the Senate has only appropriated $50 million. So what is the right number, and how do we keep moving forward with public health infrastructure improvements? Just checking our time. I think we're doing fine on time, but Dwayne, at any point, if there are questions, please, I'll just keep rolling otherwise.
Yeah, thanks, Tom. I just wanted to point out that we are using the question and answer box and the chat box. So if you have some questions that you'd like Tom's perspective on, please put those there. I had a question that has come up a number of times from our CIOs. Where do you think we are with making the payment reforms, that happen permanent? Do you see that being possible, or do you think it's a rubber band that's going to snap back?
The payment reforms from the pandemic, I would say that's a 2021 issue. That's one of the items of value over volume, in payment reform discussions that are happening. I don't see them, because of the potential price tag, I don't see them addressing that in the lame duck session, but that's more of a big issue that will need to be addressed in the new Congress. Right now, the continuing resolution to keep the federal government running runs out on December the 11th. The big focus is on figuring out if we're going to extend the continuing resolution or through to when the presidency is either turns over to the Biden administration, or however we solve the presidential election here, or if they're going to come through with omnibus appropriations of funding the government through September 30th. They're not focused on something as fundamentally or foundationally important as payment reforms and the permanence of some of those. For example, the telehealth visit being the same reimbursement rate as a face-to-face. I see that as a 2021 issue.
Okay, yeah, I was just curious if if you had got any feedback from the different, either from the,
sure,
to see where
I think
was.
That's really the case, that they'll be. Now we're in a bit of a sticky situation here, as anybody, you'd have to be living under a rock to not realize that there's some inconsistencies between the parties as to what the outcome of the presidential election is. What I'm going to do is present what we would anticipate a Trump administration addressing, as well as a Biden administration, because at HIMSS we're not in the business of prediction at this level, and we have a lot of we're a nonpartisan organization, so we've got a lot of members who want to see one outcome, and a lot of members that want to see the other outcome. So with respect to the Trump administration, if they do in some way win the electoral votes and have a second administration, many of the things that they've been talking about, they'll want to see put in place beyond just executive orders. You saw a big tidal wave of executive orders over the final 5 weeks of before the election, addressing drug pricing and reducing healthcare premiums, and really, as the president has been talking about for a couple of years now, is the end of surprise billing. From a health IT perspective, the bottom items: continued deregulation efforts, particularly around what can we make permanent from the pandemic, as well as what are some of the issues. You saw the CMS rule that was released in March of this year that tries to reduce provider burden and increase access for patients to data that was partnered with the ONC regulation that was required by the 21st Century Cures Act around interoperability and information blocking. I would anticipate that those items would remain front and center for the Trump administration if they do indeed get a second term. The other issue is around military and veterans health care, and a day like today, we're reminded that how important it is to make sure that the veterans and active duty and retirees and family members all have access to care that is continuity of care. So what the MHS Genesis, which started in Washington State and at the 5 facilities in Washington State, and has started to make its way across the United States, and eventually will be impacting the facilities like at Landstuhl, Germany, et cetera. Absolutely foresee that continuing. They've made too much of an investment in the Cerner Millennium product so far. But what the key, I think, will be for them, and then subsequently in subsequent months for the VA, and whether it's the Trump administration or a Biden administration, is the issue around interoperability. They believe that both agencies believe that they can help drive interoperability because of the care that's received at a military facility, a military treatment facility, or at a VA medical center, only goes so far, and a lot of folks are sent out into the economy, particularly in the more rural settings. So TRICARE or TRICARE for Life, as well as the VA care that occurs that does not occur at a VA facility. They absolutely want to have that longitudinal care record land in the DoD or the VA facility. So there will be a lot of emphasis on this, on completing those projects. And along the same lines, the Coast Guard, there's lots of Coast Guard activity around the United States, but no more so than in Washington State. They're tag teaming or they're teaming with the DoD around the MHS Genesis. They're making sure that they are able to advance their electronic health records. I would fully expect that to be in place. The outlier is EHR modernization for the Indian Health Service. The Trump administration started a dialogue 2.5 years ago around what to do with the Indian Health Service's electronic health record, because they were relying on open source and a lot of open source collaboration with the VA to make sure that their system kept modernizing, with the VA turning towards a commercial off-the-shelf product with the Cerner product. There's a lot of questions around how the Indian Health Service can advance, and that impacts tribes across the country. There's over 500 tribes across the country, many of which utilize the Indian Health Service's EHR, and others that utilize commercial products. But the idea of that interoperability will be absolutely key for the future. For the Biden first term, I would really want to, the Affordable Care Act is being analyzed by the Supreme Court. The cases before the Supreme Court yesterday and today, all indications of the interpretations of the first oral arguments from yesterday are that the justices were really grilling the Texas Attorney General staff and the Solicitor General from I think it's 13 different states were involved, and all indications seem to be that the justices are not going to dismantle the Affordable Care Act. But what a Biden team and what the Biden campaign has been talking about throughout the year is, how do you improve on the Affordable Care Act? Whether it's premium subsidies or just creating a public option that expands the Affordable Care Act. Those are the types of things that you would expect the Biden administration to really advocate for. The other issue that we're hearing is that the open enrollment is going to be closing off in the next couple of weeks. We would anticipate that a Biden administration would reopen enrollment to address a good portion of the 20 million Americans who have lost their employer-based health insurance because of the pandemic. We also would expect a Biden administration to address precision medicine in a way that, and really tying it to both patient access to data, as well as holding the IT community, our community, to the feet to the fire on interoperability. If you'll recall from spring of 2017, after then former Vice President Biden spoke at Health Data Palooza, and he described his son Bo's challenges of and the challenges of getting data. And the prior summer, he had focused on the Cancer Moonshot at a White House event that was at Howard University that HIMSS was asked to be involved in. All of that was really a focus on making sure that patients have access to the data, and that researchers and oncologists have access to the most accurate data and the broadest level of data and the precision medicine initiative and the cancer moonshot were really born out of the Obama-Biden administration. We would fully expect interoperability and precision medicine to make a comeback, if you will, in a Biden administration. But must address issues for 2021, and we're still doing great on time, is first off is the COVID-19 response. It's what we really anticipate, and where health IT can be helpful is the equitable distribution of PPE testing and vaccinations. As we talked about a little bit a few moments ago, the idea of a patient identification so that individual is, if it's a multi-dose vaccination, that they get both doses, and the providers get alerts if an individual needs needs the second dose and has not received it. The idea of equitable, we've seen unfortunate numbers, particularly in the minority communities, of increased exposure to COVID-19 and more limited access to care, to the types of care that's needed to overcome the virus. We think that we anticipate that the public policy decision making over the next few weeks and into 2021 really needs to address that. And then finally, around COVID-19 responses is really the issue of what are we going to do about our engagement with the World Health Organization? The Trump administration in July of this year signaled to the World Health Organization that we would be eliminating our funding and would be leaving the World Health Organization. What HIMSS anticipates is that, so they indicated in July, and you give an indication 12 months before you actually leave. So we have until July of this coming year for whether it's the Trump team or the Biden team to really point out ways that they think that the World Health Organization needs to improve or could improve, or particularly around digital health advances. And that's where HIMSS will be focusing on, is helping the United States government articulate digital health transformation opportunities for the World Health Organization that will further encourage U.S. involvement in the WHO. We've talked about the permanence of public health emergency related changes around connected health. Dwayne, the payment reform issues will be absolutely front and center for a lot of providers, because healthcare healthcare from a provider perspective is a responsibility, but it's also it's a business. You have to make sure that you can. As my brother, who's a dentist in New Jersey, he talks about, I need to make sure that the reimbursement is such that I can afford to turn the lights on, and to be able to then see the patient. So I think that that's going to be front and center for organizations. We also anticipate, just moving on down on this list here, the data privacy and digital competition. The lawsuit by the United States government against Google is a perfect example of the tension that has been built up around what to do with data, and whether or not we need a national data, an expansion of the national data privacy laws. We need an update to HIPAA. That was, if you'll recall, from back in January, it seems like 1,000 years ago, but Congress started asking questions around what does data privacy look like, and what is the next piece of major legislation need to include. And the Energy and Commerce Committee, which has responsibility for that in the House of Representatives, began a bipartisan discussion around that in January and into early mid-February. By the third week of February, they kind of pressed pause because they'd gotten enough responses to their initial question. But then, of course, by the second week of March, all eyes were on how to respond to the pandemic, and Congress has postponed the discussion around a national discussion or a new piece of legislation, a new law on privacy until 2021. We'd absolutely think that it's necessary for the discussion to occur, for new legislation to occur, and that 2021 seems like the right time to have that. Now, I'll give the Trump administration some credit around this issue, because for as early as 2015, legal experts, and folks in the Washington State chapter, and as well as other parts of HIMSS, began to raise their hand and say, we think we really need an update to HIPAA. There's so much happening in the data space, and so many challenges to privacy that current laws don't really protect it in a way that is helpful for either the individual or the organization. So here in early 2019 or late 2019, early 2020, the Trump administration took the bold step of saying, all right, let's have an RFI, a request for information. What would be the baseline changes to HIPAA that would be necessary? And they got a lot of feedback over the late winter and early spring of 2020. And then they pressed pause on putting out a notice of proposed rulemaking. But that draft notice of proposed rulemaking has cleared OMB, the Office of Management and Budget. So we would anticipate that at least the baseline would be available by the end of this year or early next year. So a Trump 2 might release it before the end of the year or early in January, or a Biden team might pull it back, take a look at what the proposed rule look like, and then by spring or summer, be able to release a version. Because as many companies, multinational companies have pointed out, having so many different types of privacy laws around the world, and some that are rather outdated, is a challenge to business. It's a challenge to them being able to provide the right level of support to providers of care. So there have been some that have said, why don't we just take the GDPR, the privacy rules that are come out of the European Union, and just overlay it into the U.S. policy. I don't think that there are a lot of folks that are absolutely want to just take that and overlay it, but having that kind of conversation is absolutely essential. Final side of this slide, and really the big issues, is interoperability that we've talked quite a bit during this conversation around the National Patient Identification Strategy. That is, it's going to play out in a lot of, hopefully it'll play out in that the Senate buys into the House's, the provision that the House has passed, and then we'll be done with the 22-year hurdle. Hurdles race, maybe a bad metaphor, but the idea there is that we need HHS actually actively engage in the discussion. The other piece that we would anticipate is that Medicaid support for information exchanges and Medicaid support specifically around the funding from the Meaningful Use Program runs out in 2021. So it's hard for folks to remember. The Meaningful Use for the Medicare side was a 5-year program. The Meaningful Use funding for Medicaid was a 10-year program, and funding runs out, and it's been relied on by a lot of HIEs to help with information advancement, technology advancement by providers to then be able to access care or access IT to be able to improve the care for their patients. But that funding runs out in January or in spring of 2021. we would anticipate that that would be, it's going to be an issue that both Congress and the next administration would want to be addressing. We finally, from a focus on value-based care, long-term viability of the Medicare Trust Fund, and then, I haven't even really touched on the equity issues so much as in disparities. So we're anticipating a really busy year. Dwayne, I see you there. I must be getting close to time or over time. But, I really, it's going to be a busy year. Lots going on with HIMSS. I would say, remember one thing. I'll just and I'll leave these slides for future. But the last item I would say is that cybersecurity, and whether or not there's been a call for governments to work together to stop cyber attacks on the healthcare sector, and come up with a Geneva Convention type protection for healthcare organizations, similar to the physical space. In a war setting, if you see the Red Cross or the Red Crescent, you know that you don't attack the healthcare facility. The same is being called for by lots of organizations, including HIMSS in the cyberspace, so that nation states stop attacking each other's healthcare systems or stop advocating for bad actors to attack healthcare systems. We saw a death in Germany recently, as recently as 4 weeks ago, attributed to a ransomware attack that was supposed to go to the local college, but instead was promulgated on the healthcare system. The patient didn't get transferred in proper time and died. And so the German authorities are starting to investigate that cyber attack as a potential murder. That's the type of thing that just is unacceptable. And as nation states need to begin to work together on protecting cyberspace, just like we all do in the physical space for cybersecurity. With that, sir, lots of going on. Just remember, when you're advocating, when you're getting involved, remember who you're working for. And for me, it's all of you. It's my family. It's all of the Medicare patients to the little children across the world who will receive better care because information and technology is infused into their care delivery. So with that, I thank you, and I wish everyone a safe remainder of the year. And thank you for all you do for healthcare and for all of us.
Tom, thank you very much for sharing. That was a lot of information. I want to let everybody know, and also for you too, Tom, we will be posting this video. Will be up on our website by next week. And so we appreciate the time you took going through that. It's always encouraging to see what our organization is involved in and how HIMSS is supporting the local provider network, as well as on a national, international level. So thank you, Tom, for your work, and thank you for presenting today. I wanted to point out that tomorrow we are moving into our final virtual summit, which is going to be remote work with Ellen from Virginia Mason. This will be a second session we've had on remote work, and this will be focusing more on post-COVID. So we've brought together most of our CIO panel as well, and it's going to be a robust discussion. So I hope to see you tomorrow, 1 o'clock. Again, thanks, Tom. Thank you, everybody, for being here. And again, a special shout out to our veterans and veteran families. Have a great rest of your day. Thank you.
Thank you.